Welcome everyone to this, our 29th session of Revolutionizing Healthcare. We're just about to hit another milestone and with our next one. So it's really exciting to see how long this journey already has been and how far we've come. And today we'll be talking about timely and early diagnosis in many facets. For that, I'm very happy that we have Tim Schubert and Tim Oosterlinck back to guide us a little bit through the session and the little choreography they designed for this. It worked very well last time. It was very interactive, and today as well. So over to you, Tim.
So we have our first poll that we're going to ask in the beginning of the session, asking why early diagnosis is not a reality for many patients. It's very nice to see that we have a wide range of answers, so that will be very interesting for the discussion. It's really good to see that not everybody has the same opinion. It's always nice to see. And let me now introduce the panelists. If Andreas could, we'll be joined by a host of expert panelists who have been thinking long and hard about this problem, about this new concept. First and foremost, by Dr. Camelia Davtyan, who is a clinical professor at UCLA, also director of Women Health and Comprehensive Health Programs, and associate director at UCLA Medical Hospitality Program. Thank you for joining us. We also have Professor Richard Peck, professor of pharmacology and therapeutics at the University of Liverpool, UK, and also a former global head of clinical pharmacology at Roche in Switzerland. We're also joined by Professor Henk van Weert, who is professor of general practice at Amsterdam University Medical Centers in the Netherlands. And lastly, also by Dr. Alexander Gimson, who is associate with the Cambridge Center for AI in Medicine and a former consultant transplant hepatologist at Cambridge University and the NHS Foundation Trust. Thank you for joining us. We have a whole range of countries who are joining us. We're also joined by Professor van de Schaar and Tim Schubert. Professor van de Schaar, would you like to start us off by giving us your perspective on early diagnosis?
Well, I would like to start. Thank you very much, Tim, and thank you very much to our panelists for joining us and everyone who is on Revolutionizing Healthcare with us today. I would like to start not by talking first about early diagnosis and detection, but rather providing a little bit of context. And the first thing I'd like to say is that this is not the first session we have on this topic. As a matter of fact, more than a year ago, we have had a session entitled what can machine learning do for early diagnosis and detection? And actually, what we focused in that particular session was the early part of a journey, which has to do more with screening rather than early diagnosis. So you see here a diagram that I have taken away from the World Health Organization. And what you see here is that there are these two parts associated with the early journey of a patient, where maybe a patient is discovered with a particular type of diagnosis through a screening program, and then the later part of the journey. What we discussed in the previous session was much more focused on screening and screening programs. So in that session, we talked about what can machine learning add in terms of personalized risk, competing risk, and how we can integrate easily diverse sources of information using machine learning to do more accurate and personalized screening. And we talked about how machine learning can improve accuracy, uncertainty quantification, and provide a good understanding using interpretability of what factors have been important. And what we have discussed at that time was the use of autoprognosis, this automated machine learning tool that we discussed in quite a lot of sessions, and more recently has been revamped in Autoprognosis 2.0 as a tool for personalized screening. But the reality is that what is truly exciting, if it is to talk about early diagnosis, is about patients which may have symptoms, and or may just feel something, some type of sign. And in that particular case, the true diagnosis and early diagnosis starts. And this is a very complex process. And I took here two different slides that I found from the BMJ. One is about childhood cancers, and the other one is about adult cancers. And you see here the journey associated with different suspected cancers. And what you see in this type of diagrams that were produced by NICE is that the process is complicated. But you also see a few other limitations if you are thinking in this way about early diagnosis. First, you see that this process is not personalized, but rather somewhat one size fits all. Also, you see that in the diagrams that I just shared, the discussion of whether you should be waiting and see whether the disease is unraveling or not is not addressed. Also, when and with what type of diagnostic tests a patient should be further diagnosed is not addressed. And also, if a particular diagnostic test is provided, depending on the findings, what should happen next if the diagnosis is not definitive? All of that is missing in the early diagnosis frameworks that we found online. So this is why, out of this need that we perceive, that early diagnosis really not very clearly formalized and very clearly understood, we started a journey together with Tim Schubert, who was visiting me in Cambridge in our lab, and together with three clinical collaborators and friends, Camelia, Richard, and Alex, we started to think about this very complex problem of how can we formalize correctly early diagnosis. And we went back and discovered a lot of literature that says something about this journey, but we were not satisfied with what we found. So this is why we started to develop together this framework, this foundational framework of early diagnosis, about which we want to tell you about today. And we want to tell you where we are at and get your opinions. Hopefully this provides a little bit of context about the session.
Thank you, Professor. Next, I would like to give the word to Dr. Alexander Gimson. Could you give us your view on the subject, please?
My name's Alexander Gimson. I'm one of the faculty members of the centre here in Cambridge, and I'm just going to give a few words very, very quickly about some clinical perspectives on the whole issue of whether we should be talking about early diagnosis, which is just a diagnosis that occurs earlier than it might otherwise have occurred, or what we would like to consider timely diagnosis, which would describe a diagnosis that is more closely linked to an individual's specific circumstance. Now, as I think Mihaela has said, many national bodies, including in the United Kingdom, National Institute for Healthcare Excellence, but many other national bodies, including the World Health Organizations and the NIH in the States, have wanted to make earlier diagnosis a national imperative. But when they do that, they often speak as if it's axiomatic that any earlier diagnosis is always the best option for the patient. And indeed, in the whole clinical course of a patient, it's never really defined as to what the earlier point might be. And so we're introducing this concept of a timely diagnosis, and people have written papers about the important difference between timely as opposed to early diagnosis. Timely, importantly, as Mihaela has said, would be individualized because it is the best possible point for any individual to have the diagnosis made, which will optimize their outcome. Now, clearly, diagnoses, and we don't need to rehearse all these arguments, have has clearly some benefits. For the it will diagnose a disease at an earlier stage when it is in a more treatable state. Clearly, it will facilitate planning for the future. And it maximizes the opportunity for patients to contribute to their own management. I mean, from my personal clinical experience, I mean, leading a transplant hepatology program, a very significant number of patients arrived to be considered for transplantation in our centre when they were too late to benefit from that treatment, and they would have clearly benefited from an earlier diagnosis. But when is that earlier diagnosis? And in some diseases and disease processes, there may not be benefits in earlier treatment. The earlier in the clinical course you institute a treatment, then the side effects of that treatment may outweigh any particular benefits in the outcome. Although everybody speaks strongly about the importance of earlier diagnosis, there is some lack of evidence that well-being as well as longevity are also improved by earlier diagnosis. So I just put this slide up just to emphasize that there is a balance to be struck between trying to always diagnose early and making sure that when you're diagnosing early, it will be to the benefit of the individual. So we have to weigh up the benefits and the risks of that earlier diagnosis. And there are a few considerations for which Mihaela has spoken about some of them. First of all, it will depend on the individual. So the benefit of an earlier diagnosis in someone aged 25 may be very different to the benefits of earlier diagnosis in someone aged 5. It's very specific to the individual. It's also very specific to the symptom that they may be presenting with. So if one takes an example of people presenting with a cough, there are very, very wide range of differential diagnoses, some of which will resolve spontaneously with minimal treatment over a short period of time, some of which are often significantly less common and for which there will be significant uncertainty in the diagnosis, but which are extremely important, for instance, bronchogenic carcinoma. So in those circumstances, there is a considerable balance between the prevalence of the different diseases that are being considered and the importance of early diagnosis in each of those different options. Another condition may be like memory loss, of which maybe there is a much narrower differential diagnosis, which would include different forms of dementia, where the benefit of early diagnosis in terms of outcome may be less clear than it is for some other conditions. So we have to consider the way in which we weigh up the risks and the benefits will be specific to various symptoms. Earlier differential diagnoses are also associated with greater uncertainty. So the earlier we do that, then the range of diagnoses is wider, and the uncertainty relating to those diagnoses increases. And we are expecting clinicians, when presented with people in their surgeries with a cough or memory loss, to try to assess the multiple different options that they may have to consider in terms of management and the outcomes from that management, and various counterfactual options. What happens if I don't intervene in this case? So we have been trying, and I think I want to just to mention, we've been trying to work through some of the ways in which those decisions and their outcomes and the probability of those outcomes will happen from a single point in time. But that complexity of treatment decisions and outcomes just describes a single point in time. Many diseases have got some sort of evolution, and which range from the very earliest investigations to the very late investigations, and trying to identify between extremely early and much too late. investigation. The most timely diagnosis should be found for that individual, for that specific symptom, is what we are looking to investigate with new machine learning methodologies.
We're also joined by Professor Camelia Davtyan. Thank you for joining us today. How do you see this early diagnosis being implemented in the clinical setting?
So first, I'm just going to say that as a primary care doctor, my clinical focus is just providing primary care to patients. I deal with uncertainty every day. And I'm going to start with referring at that first question that you polled the audience on. It was interesting that if you look at the answers, there's not an obvious majority there as far as a single choice. That's what I do every day. You know, the patient comes in with, let's say, chest pain, and then I have a variety of different paths that I have to choose as a clinician. So my dream would be that I'd be able to have a tool to help me because it's very hard to really come up with these probabilities very accurately as to what a certain symptom or a constellation of symptoms would mean in a certain individual. Let's say if somebody comes in with chest pain, which is a common symptom, I think about it differently in a 25-year-old woman with no risk factors versus a 55-year-old man with cardiovascular risk factors. So it would be really amazing if a tool would be integrated within the electronic medical records of the patient to identify their personalized information, you know, and be able to come up with some sort of predictions or at least an early indication as to what would be the best course of action, or rather courses of action, because there's never or rarely ever a single one. So I feel that creating a framework of understanding more formally these notions would be really helpful, because oftentimes we learn these things in medical school and they're not necessarily taught in a very formalized fashion. So to create a bridge between us clinicians and the machine learners who haven't gone to med school and they haven't got that clinical instruction would be amazing, to be able to formally diagnose these steps that we use on a regular basis, on a daily basis, to diagnose our patients, and to be able to create this tool that would be able to help us every step of the way. And of course, there are many confounders and, like I said, a lot of uncertainty in what we do every day. And it would be really wonderful if that uncertainty could be formally reduced, because oftentimes we start with common things are common. So we go for the most common diagnoses and then we try to rule those out and then move on to another whole set of actions to be able to eventually arrive at the final diagnosis. So my vision as a primary care doctor would be that at some point in the future, I'd be able to have this helpful tool that would be able to do better estimates for me, and also help me even with screening. You know, when somebody comes in without a symptom, there sometimes more than one screening method. Let's say colon cancer screening, you know, it can be fecal occult blood testing, some immunohistochemical tests versus a colonoscopy. So depending on the patient, it's always good to have, you know, clear estimates as to what would be the sensitivity of these methods and what would be the outcome. And oftentimes my decision is clinical, but I don't have the actual exact numbers in my head because I just can't remember all of them. Maybe some other doctors can, but I certainly can't. And definitely not for every test or for every procedure that we do in our patients. So I feel that this initiative is essential in terms of what it can achieve in the future, but also, like I said, as a bridge between us clinicians. In a way, you know, this has become a second nature for us to act this way and go from step 1 to 2 to 3 in our diagnostic paths. But our collaborators on the machine learning side don't know exactly how we function. So it's really nice to create a framework so that they can understand what we do and where they can help us.
Thank you, Dr. Davtyan. Let's also hear again from Professor van der Schaar, our machine learner in the room. I think we all agree this is a very complex subject. Could you introduce us to the framework of this early diagnosis?
With this in mind, we went to the drawing board, and together, as I mentioned, with Tim, Camelia, Alex, and Richard, we wanted to build a foundational framework for personalized early and timely diagnosis. And in order to do so, we provided a set of definitions which we feel are essential in order to create a rigorous formal language to describe our framework, but also other frameworks that others could envision. Also, I'm going to say that our framework builds on decision theoretic approaches in order to build a systematic way of thinking about the diagnosis process, but combine this with machine learning and statistical methods, because in this decision theoretic framework, in order to enable personalized early and timely diagnosis, we need to provide estimates, to learn estimates about the optimal personalized diagnostic path for a patient. So why something new here? Why has this not been done before? The reality is that approaches based on decision theoretic models have been already proposed as potential solutions to conceptualize the diagnosis process. However, they are not individualized to the specific characteristics of the patient. So for instance, when you see these nice diagrams, for instance, that were published in the BMJ, or when you often see in a medical journal, decision theoretic diagram, it is of a population level. It is not individualized to the patient at hand and their unique characteristics and the unique information that has been gathered about this patient so far. Also, they assume that the costs and benefits are known. This is not the case. Definitely at the personalized level, one needs to learn from data what are the benefits and costs of yet another diagnostic test. Somebody put in the chat a Galleri test. It could be a Galleri test, it could be a specific MRI, a CT scan, an ultrasound. What will be the benefit for this individual patient, given the information we have so far, to do this particular test? This needs to be learned and estimated from data, and existing ways of thinking that we have seen so far do not have that taken into consideration. Now, this is why we build this foundational framework for personalized early and timely diagnosis. What we are after in the end is to create a diagnosis. We want to help build a decision support framework in the end on the basis of this foundational framework for clinicians such as the ones that have joined us today. And this diagnosis is nothing else than, if you like, a label of the exact disease, or for that matter, health, applied to a person at a specific moment in time. Of course, as Camelia has said, this is a complex process that involves uncertainty. So this is why we introduce in our framework another concept, that of diagnostic uncertainty, which talks about the manifestation in terms of information deficiency expressed in terms of probabilities. In order to reduce the diagnostic uncertainty, we need to gather additional information. This is what we call diagnostic information, and the value of this diagnostic information is with respect to providing reduced uncertainty and reduced diagnostic uncertainty and diagnostic ambiguity. Then, in order to gather such diagnostic information, we need to take actions. These are diagnostic actions. And diagnostic actions could also include waiting. So it doesn't need to be necessarily a specific test or a specific, it could be that it's a specific test, like a Galleri test or an MRI test or an ultrasound, but it could also be waiting. And these actions come associated with it with timings. So it's action at a specific time, and its goal is to increase the information in order to facilitate diagnosis or make diagnostic decisions. If this is done over time, this creates diagnostic paths. So what you see here, for instance, in blue, is a diagnostic path that was chosen by a clinician in possible consultation with a patient. After a series of diagnostic actions were taken, the clinician will arrive at a diagnosis. And we have the concept of diagnostic decision, which is the choice potentially of a subsequent diagnostic path. So it could be that one goes in one particular path and then subsequent decisions are taken. Also note that at every moment in time, multiple paths may be possible, and the costs and benefits for the individual patient, as well as the uncertainties associated with this, are computed and provided as information to the clinician. This is done in a personalized way for the patient in front of the clinician. Now, why do we need this clear framework? Many reasons for it. One of it is to have this time a very concrete and precise definition for early diagnosis versus timely diagnosis. Till now, this type of difference was mainly done in words, but now this is much more systematic in our framework. And for instance, early diagnosis is diagnosis following the diagnostic path, which results in diagnosis at the earliest possible time, and this can be computed. And timely diagnosis is diagnosis following the diagnostic path with the highest diagnostic net benefit. And again, this can be computed rigorously and systematically in our framework. Why now? Why are we excited about this now? This cannot be done without an underlying estimation of the different the net benefits and cost associated with particular diagnostic options for the patient in front of the clinician. This can only be done by estimating that using machine learning from data. Some statistical methods may also be very helpful here. So it is this excitement of machine learning and statistics being able to estimate in a personalized way these benefits, costs, and probabilities, and doing this sequentially across the different pathways. Now, why is such a foundational framework necessary? We need this type of formalism to provide clarity for the development and implementation of machine learning models to support the diagnostic decision-making tools that Camelia would like to have, and I hope many other clinicians would like to have. It allows us to have very clear and rigorous definitions for early and timely diagnosis. It enables us to determine time-dependent costs and benefits and understand choices. Do we need a Gallery test for a particular patient? Do we need an MRI for this particular patient? When? And determine and be able to evaluate by the clinician and potentially for shared decision-making, clinician and patient, and understand the potential diagnosis paths, the uncertainties that are available, and the uncertainties that remain if a particular diagnosis action is not taken, and what remains. Often I, as a patient, am given a partial diagnosis, and I'm not given the uncertainty associated with that. Maybe not all patients need to know that, but I think it's important to know what the options remain and what additional diagnostic tests could provide. And this is now possible within this framework in a very rigorous way. Also, a rationale emerges to systematically assess in this way the value of technologies, the value of new diagnostic tests. We are bombarded at this moment in time by more and more diagnostic tests. Are they valuable? When? And at what moment in time? And for which patients? And this is not only true about diagnostic tests, it's also true about machine learning and statistics. What's the value of these methodologies to improve the diagnostic pathway and when? And finally, what about costs associated with the healthcare system? This personalized approach can not only empower individual patients and clinicians looking after them, but also make sure that the right tests are given at the right time to the right patient, thereby unburdening healthcare systems. So we are very excited because we feel that diagrams such as this one, which I took from the Cancer Research UK in Cambridge, which are only talking about the challenges, we now have concrete solutions that can provide answers to these challenges. So we hope that this foundational framework which we are building can unlock this long-awaited potential of timely and early diagnosis and intervention, because we have now a very clear conceptual framework that enables us to evaluate the different options and interventions and empower clinicians and patients.
Mihaela already introduced the framework extensively, I think, and very nicely. And I would just like to bring this all to life by giving you the example of one patient where this framework is applied. So this is Susan. She's a 70-year-old woman and presents to her GP with a persistent cough for over 5 weeks, which keeps her awake at night. And overall, as Alex discussed, the goal would be to reach a timely diagnosis. So Susan's cough syndrome is associated in the population with several diagnoses that are more common and some that are less common. And for example, bronchitis will be far more common than suspected malignancy. But this epidemiologic data, of course, is not individualized to Susan at all. So we still have a lot of diagnostic uncertainty, right? And this can be expressed with these probabilities for various differential diagnoses. And the more information we gather on Susan, specifically, the lower this diagnostic uncertainty will become. So here's some more information on Susan. We can learn from her EHR that she previously had seasonal chest infections, that she smoked a lot of cigarettes in the past, has a BMI of 37, history of hypertension, and is also treated with ACE inhibitors for that. And we also learned from her that her cough is worse at night. She does have reflux symptoms and is dyspnoic on exertion. And we also get some data from the examination, of course. And what you now see is some, of course, very simplified, and there may be much more data from genetic background all the way to previous treatment responses, etc. Now, Susan's pie chart would look very different from the one that we just saw with these differential diagnoses, now that we have more information. For example, side effect of ACE inhibitors and post-infectious cough, but also a carcinoma of the lung would become more relevant for her than for the general population and more probable. With this, there are a couple, again, this is simplified, but there are a couple of options for diagnostic actions for Susan. For example, watch and wait may be a good approach if the diagnosis turns out to be post-infectious cough. However, this would delay the revelation of other diagnoses. Similarly, if we were to stop ACE inhibitor therapy, this could reveal whether this side effect from a medication is the cause of Susan's cough. But this would probably take about 1 to 4 weeks, or even up to 3 months. And even though it is less likely, if Susan turns out to have lung cancer, a lot of time would have passed by now. And this differential diagnosis of lung cancer could be confirmed much quicker with tests that involve higher risk for patient harm, are more time and cost consuming, but also reveal the underlying diagnosis much quicker. And this could be something like a CT scan and subsequent bronchoscopy. Now, given Susan's unique characteristics and this information that we already observed, and then these calculations that Mihaela explained that we can make to assess the probable future disease trajectory that Susan will have, and therefore the net benefit of each diagnostic action that we could take right now. The diagnostic path with the highest net benefit may be to immediately perform chest X-ray, which would, in Susan's case, confirm the non-small cell lung carcinoma. And usually chest X-ray is only routinely recommended for chronic cough. So in Susan's case, her GP would have typically waited longer to administer this test. Overall, what we see is that if we individualize our diagnostic paths to the individual patient and aim to find a diagnostic path with the highest net benefit, we can reach a diagnosis that is timely for this specific patient. And what is also important to note is that these different possible paths that are also shown here, they are the possible paths for this patient, and this tree will look different for other patients. So this needs to be highly individualized. Thank you so much. And I'm really looking forward to this discussion, and please ask questions in the chat. Thank you.
Thank you, Tim, for this clinical example. We also have with us Professor Peck, a clinical pharmacologist, whose work extends to personalized treatment effect estimation. What do you think the relevance of this framework is, and how do you see this going beyond diagnosis alone?
So I'll come to that in a minute. I just want to pick up on a couple of things that have already been said, if that's all right, Tim, and I promise I'll be quick. First of all, just building on what Tim Schubert's immediately been saying, I suspect there are some people listening to this who are thinking, yeah, I didn't need machine learning to know that a chest X-ray was probably a good idea in this case. And that may be true. But I also encourage you to realize that there will be many other cases where the potential diagnostic uncertainty is much greater, and it will not be quite so obvious what the simple option might be and what the option with the best net benefit might be. Secondly, there was, as you heard, basically my background is drug development, clinical pharmacology and drug development. I've already noticed a question in the chat about some of the implications of earlier diagnosis with regard to building more effective therapies. I think that's a huge opportunity, no question about that. I mean, what we've already been seeing with several drugs in recent development, perhaps particularly the neurodegenerative ones in Alzheimer's disease, is that the opportunity to use them has been moving backwards in terms of the disease. They started off in patients with already diagnosed Alzheimer's, and now, frankly, most of the trials are being done in patients who are at risk, who may have some cognitive impairment, but who do not yet have Alzheimer's disease. To have a more granular, but also a more agreed and consistent definition of timely and early diagnosis, I think will be a huge help in drug trials, because we'll actually end up then with trials of different approaches being done in the same patient population. And it should be much easier for many of you to be able to compare between them and to understand what the choices would be. As Tim's already mentioned, one of my interests is, that we, as well as individualizing the diagnosis, we should also be thinking at a much more individual level, what's the treatment we should be applying? And I think many of the same methods that will be useful in understanding the individualizing of the diagnostic path are also going to be helpful in understanding and us providing guidance as to what's the optimal treatment for an individual, moving beyond the sort of population level choices that we have to make from randomized trials. And then one last quick point to pick up on something Camelia said when talking about the kind of tools that would be useful. Well, the good news is that actually they already exist. They're not used in diagnosis, but tools, CDS tools, clinical decision support tools that are embedded within electronic medical record systems and electronic prescribing systems undoubtedly exist for helping to guide the use of some drugs, in particular those where there's a need to measure the concentration of the drug and then adjust the dose, vancomycin, tacrolimus, these sorts of things. the tools exist that can be where there's no requirement for any manual entry of data. The tool pulls the information directly from the electronic medical record and or the electronic prescribing system. The complex population pharmacokinetic model that does the calculations is in the background, and the output can be, it could be basically, for this patient, you need to do this. Or it could be, here are some choices. If you do this, this will be what will happen, and so on. And the physician, the healthcare professional, can take whatever output is most useful to them. Those tools could easily be adapted to incorporate a different type of model generated from the sort of machine learning context. So I think that's not a technological barrier either. I'm going to stop there, Tim, and we give some more time to other speakers and hopefully for some other questions.
Thank you so much. And lastly, we have Professor Henk van Weert, and probably the most important panelists for our discussion today. Would you be able to offer your feedback on the early and timely diagnosis framework? And what do you like and what do you don't like about this framework?
Yes, thank you, Tim. Because the other Tim paved my path, to be honest. In his story about the lady with the cough. I mean that's a real general practice problem, coughing, and that's also a symptom which we often neglect because it happens so often. But a symptom which can point out to very dangerous diseases, as we all know, and also a symptom which we did we did research for to search for a method to diagnose lung cancer more early than nowadays happens. And the discussion about timely and the difference between timely and early is not so important in this story because all my patients will have lung cancer. And what we did is we collected the files of general practitioners of about 200,000 inhabitants in Holland. And from those 200,000 people, we chose the people with lung cancer and to compare them with the others. There might be other cancers, but also patients with a cough or patients who don't even visit their GP. And we used a text analysis to see whether or not there were differences between the group with cancer and the group without cancer. Of course, there are known symptoms. Willie Hamilton in the past did lots of research to predict the presence of cancer, and he found about 10 symptoms which are quite predictive. But even then, patients were much too late. As you know, people come into care, specialist care with lung cancer, and then about 90% has a metastasized cancer, and is therapy often don't give much results then. So we were looking for times earlier. What we did is we analyzed the data 1 month, 2 months, 3 months, 4 months, 5 months before the diagnosis was established in these files, and we were looking for predictions that could say which patients had a cancer and which didn't. And honestly, we found them. Of course, I can't tell which symptoms because we used the method which does not provide the symptoms, but provides the chances for each person to have or not to have cancer. We were able to identify a patient with certainly about 5% positive predictive value for lung cancer, which is very high in general practice. And we also were able to exclude the cancer in about 99.96% of the patients, so almost everybody. So in just running the data which were present in the files of the general practitioners, we were able to raise the chance with people who came to general practice to 5%, 5% positive predictive value for cancer, which means that you have to make an X-ray or maybe a low-dose CT scan with 20 people to identify one. That's much better than we would gain in doing just a normal population screening program or something like that. And it is also not so harmful to do a low dose CT or to do a normal X-thorax, which is also possible. So, Tim, there are ways to identify patients with cancer more early than we do nowadays. And in this project, we win about 5 months, which comes down to about 20% reduction in mortality, which is very high in normal clinical practice. So there are hopes for machine learning to use in great databases real time in general practice, which will also be helpful to Camelia, I think, because if I remember well, that was one of her wishes. Do I have to say more?
Professor, that's a very interesting view also on the case of Tim. And how do you think this would fit into the framework that we established in this session? Or do you think that it can?
Yeah, I heard so many things, Tim, to be honest. Professor Gimson started to say that the cause should be known of the disease, well, which is the case in this, if it is a cancer, it's well known, because almost everybody will pass by. And a thing I very much need to know is if a later diagnosis causes harm. So if you want to diagnose earlier, you have to be sure that you're doing something good and avoid harm later on the time, which of course is the case. Not only is the case with all kind of cancers we're talking about.
Henk, if I may interrupt there a little bit. So I think that this is exactly what this framework can do, because it can evaluate, it can show a very rigorous and systematic evaluation of benefits as well as costs of different types of tests and interventions, which, as far as we know, we have not seen anything quite like this so far. So I think that I kind of agree with what you are saying. I think some of the tests may be very beneficial for some, but very harmful for others, partially because they may lead to false positives, if I'm correct. No, so that understanding for a particular individual is what we would be able to assess systematically using this framework. I don't know whether some of the other co-authors would like to add to this.
But that's quite possible, Manuela. If you, Mihaela, if you look at this kind of research, you can assess each person's risk. You even can put the threshold on beforehand. You could say, I would like a risk of 5% acceptable, or 2%, or 20%, whatever.
Yeah, it's just.
I mean, you can gamble with figures, to be honest.
No. So what I'm trying to say is the fact that so far we have seen no framework which is considering not only one step, but rather this multi-step decision, which, depending on what one particular diagnostic action may reveal, what are for this particular person the likelihoods of other things happening, and doing that systematically and correctly to estimate for an individual benefit, net benefits and net costs. Well, we have not seen anything quite like this in the literature, and we think that this type of analysis would be very helpful for the type of example you mentioned.
Yeah, we have some difficulties in publishing it, to be honest. But we can talk that later.
I'm going to jump in and also add a question from the audience, a very good question. Ravi, could I ask you to unmute yourself and ask your question? And Richard, could I ask you to try and answer the question? Thank you.
Thank you very much. So I think Richard answered this question to an extent, actually, which I think is really interesting. I mean, ultimately, I think so I'm a clinician by background, but I now focus a lot of work on research around early detection tools for neurodegenerative disease, and seeing how we can use that to translate it into new therapeutic discovery as well, particularly for these diseases where, for example, early detection has never been possible. I find it really interesting, the distinction, because as a clinician, I think, yes, timely diagnosis, the idea of what is actionable for the patient is really, really important, right? Because, you know, some of these diseases have stark consequences where asymptomatic diagnosis is actually probably damaging for the patient and for the patient experience as well. But then again, when we think about these diseases where outcomes are really terrible, I've always believed that actually earlier detection of disease will just afford us more biological understanding that can help us build better therapeutics and, you know, better assets. So I think it's an interesting balancing exercise. And, you know, I think that it seems as if there's definitely room for both, and perhaps it's just very contextual. You know, for some patients and for some clinical settings, a timely diagnosis is the most important thing, and maybe that's where we should err. But in fact, earlier detection, earlier diagnosis, in the right context with the right additional resources, can be really beneficial for the system at large. But I think, you know, just some thoughts.
Maybe I just add one point. We're talking only about half the question at the moment, and I'm not the best person to talk about the Grail piece. So if someone else wants to have a go at that, that's great. But I would add one additional point to what Ravi said. I think for me, particularly when you think about degenerative conditions, and that includes the neurodegenerative conditions, but also perhaps something like rheumatoid arthritis and osteoarthritis, for which there aren't that many treatments yet, but there are for rheumatoid. A key question that we really struggled with actually in pharma was, you know, trying to understand not just which patients were at risk of developing Alzheimer's. And if you read the diagnostic criteria for Alzheimer's, you're pretty badly impaired by the time you actually meet the diagnostic criteria. So you don't want to wait that long. But, you know, which patients are going to progress relatively quickly and which are going to progress quite slowly? So it's not just about coming up with a diagnosis, you know, and saying, okay, job done. It's actually about understanding much more about how that's going to translate into a subsequent time course, because that's also going to impact on what you're going to do with the patient subsequently and what they're going to want you to do.
If maybe I can comment on the Galleri test. So I think, Ravi, for both the Galleri test as well as other tests such as those, what is the value of a test for an individual? And what is the value of the test for a group of individuals at a certain moment in time, given their journey so far? As far as I know, there is no way prior to this framework to assess accurately this from data. People do not have ways to think even about that and formalize this problem correctly. So I'm a very big fan of new diagnostic tests such as the Galleri test. And I think that one could use this framework that we propose to estimate the benefits of such new tests. For whom, when, and what are the benefits and costs associated with it? So the answer we cannot provide, but given data, our framework can provide such information. Hopefully this answers your question.
Can add a quick
Mihaela,
comment about the Galleri test. So first of all, Galleri test is not a test that's considered standard of care, at least not in the US. It's about $1,000 per test. Some of our patient population here in the US is specifically asking for the Galleri test, and I don't know if everyone in the audience is familiar with what this is. This is a test, a blood test that looks at abnormal methylation of certain proteins, and it is really not 100% accurate. I think the overall accuracy is about 85%, and if you break down different cancers that it may predict, some of them are as low as 5% accuracy. So it would be, again, helpful to have a machine learning tool to be able to let us know what would be the best patient to order that test for. But also in the big scheme of the healthcare system, it's very unlikely that unless this test value decreases to an acceptable level, I don't see, even in the US, a recommendation to screen everyone over 50 every year with a Galleri test in the hope of an early diagnosis of cancer.
Thank you. And I also would like to have another question from the audience, because it really opens up the discussion. Shivangi, could I ask you to unmute yourself and really quickly ask the question?
Am I audible?
Yes.
Yeah. So my question was that, like, in my country, I have seen a lot of times that, I mean, ever since the onset of COVID, heart attack, cardiac arrest has been a very common symptom. A few days back, a 9-year-old kid, she died out of cardiac arrest. I mean, looking at the symptoms and all the classifications that we have for cardiac arrest, we wouldn't expect a 9-year-old, who appears healthy to die of cardiac arrest, right? So can this framework actually help in those cases, maybe for an early or timely diagnosis, maybe as a routine test?
Maybe I can comment on that.
Yeah, sure. Thank you so much.
Thank you. Could you mute yourself again?
Sure.
Thanks. Thank you. So, I mean, of course, this would have to be very well thought through, right? We need to develop the proper methods, test them in clinical trials and everything. But if you would actually get this to work, then the idea is that you would sort of optimize the diagnostic path for each individual patient. And of course, this will take longer for less common diseases. But if we can get it very personalized, then we can still find the path with the optimal net benefit. And this also, what also factors into that is another question that was asked from Anna, that was on personalization and patient preference. And patient preference is also one of the things that determines whether a certain diagnostic path will have a higher or lower net benefit. This is the important thing to understand, and this is the power of this form of thinking, that it's very adaptive to individual patients, but it's also adaptive to changing circumstances, right? To changing health systems, to changing, for example, in a pandemic, the trees would look different in a pandemic than they would look in normal circumstances. And I think this is the sort of power behind it, that even for very rare diseases, you would aim to find the best way to diagnose them early. Yes.
I'm sorry to interrupt. I have one more question. Okay, so the question is that, I mean, I belong from India, and in my country, I have seen a lot of patients who might have symptoms, but they won't come to the clinician, until unless the symptom gets actually worse, maybe you're on the last stage or something. And that's very difficult, even after having a system or a framework like this. If patient doesn't come to us as a clinician, we can do nothing about it, right? And can we incorporate this framework? Am I audible?
Yes, you are.
Yes, you are. So can we somehow incorporate this framework in a recommendation system, like, I mean, Apple Health, Samsung Health, or something like that, that they could get certain alerts based on their symptoms that they are, sharing with the app, or maybe some record or something, and they could actually get recommendations that this is something getting serious in here, and you need to visit your clinician, or this is time for you to go to your clinician based on that symptom, so that we could help them out until the symptom actually gets worse enough.
Thank you for making this point, because it's very important, right? We need to get patients actually to go to the healthcare system, right? To then start this diagnostic path. And I think what you just suggested is already a good start. I mean, we have screening for certain diseases, but an additional thing to consider would be something like background monitoring a patient's health status, or a person's health status who's not a patient yet, to get them to the clinician in time. I think this is a sort of separate issue, but it, of course, factors into this.
And thank you, Tim. And also because Anna, do you have any other questions? Because your last one was really good. And I was wondering if you had some other questions about this topic as well.
Oh, thank you. Yeah, no, I first of all, I just wanted to say, I think I'm really excited by the framework. I think one of the things also I'm thinking about application. So I'm a child psychiatrist, and one of the huge problems we have is about how to effectively signpost children through a system. So we've got a huge prevalence, but there's also a great variation in need from, and that's, you know, children that can be managed really effectively in the community versus those that need tertiary services. At the moment, everyone gets sent into these, you know, tertiary services, and we're clogging up the system. So it feels like this is a great way of kind of effectively signposting. One of the things I did wonder about is, though, with mental health problems in particular, I'd say there's probably a lack of definition of what the greatest net benefit is. And I'm not sure if I'm misunderstanding the approach, but so an example might be a young person who's really, you know, 9, 10 maybe, who's got some sign of some kind of social emotional problems, maybe on the autistic spectrum, but maybe they're a little bit more on the side of being Asperger's rather than being severely autistic. And for some people, the diagnosis might not be helpful, or the definition of net benefit might not be very clear. And I'm just wondering how this framework can be tailored to those kind of situations, and whether it matters if we don't have a clear definition, and how patient preference could be incorporated.
Well, I'll say a few words, but then maybe some of the other co-authors can. So definitely, I think, Anna, this is very exciting. So first, definitely patient preferences are part of it, because this framework could be discussed potentially with a good user interface to see the options associated with this and what interventions can come associated with different types of diagnosis. And even if uncertainty remains about a particular type of diagnosis, one could identify whether interventions could be associated with it, and only go through this diagnostic path when a clear intervention exists. And otherwise say, I'm not interested even in diagnosing, because short of labeling, there is nothing I can do about this particular individual. So while in our current framework, what we have at the very end is, if you like, a label of disease, I think we could also use the same framework or a similar framework to put interventions at the end and the effect of these interventions associated with this.
Thank you. I think it's quite exciting in CAMS at the moment. There's a big model of care called Thrive, which is emerging as the predominant model for children and children's mental health. And part of that is being able to identify at a really early stage the level of need that's required. So it's rather than taking a diagnostic approach, it's a needs-based approach. So it's like, is it a low level? Do you just need advice and signposting? Kind of a moderate level intervention that we manage in the community, or more intense one, or very, you know, multi-agency kind of approach. And one of the big challenges is how we can effectively, I should say, identify, but also suggest which pathway children should go through based on that. And this is really exciting in terms of thinking about how you might provide a mechanism to do that digitally. And I think the other opportunity as well is in services in which there's a there's a significant emphasis on diagnosis and management being with professionals who maybe aren't all medics and don't have the same kind of diagnostic expertise. Having a digital support system to support diagnosis and signposting in the community is also something that I think would be really useful as well. So no, it's exciting. Thank you.
Thank you so much, Anna. Unfortunately, these discussions always have too little time to keep talking about them, but could I maybe ask each panelist for a 1-minute final statement, if possible, about the subject? And I would like to start with Dr. Camelia, if possible.
Yes, so essentially my final statement would be that I can't wait. I'm very excited, and I can't wait for further development of a tool like the one we've discussed that would be helpful, estimate all the uncertainty in my effort to diagnose patients in my clinical practice, and help me better estimate the different pathways that I may choose to give them the best care that I can give them.
Useful. Thank you. let's go to Dr. Gimson.
Yes, I'm just going to pick up on the comments that Anna made just now. I would emphasise that we would recommend that patients are involved in all points of the decision-making process, deciding not only when but what tests to do. But to do that, they would need information about what the potential trajectories going forward with each of the options that they are being presented with. But and that's particularly important, as she says, with psychiatric diagnoses, the outcome, what outcome, and what is the optimum, what is the definition of the optimum outcome, shouldn't be externally applied, but should be what is optimum for that individual patient, and that will change from different individuals at different ages in their life.
Thank you. Henk, could I get a final statement from you, please?
Yes, to start with, my apologies, because it was not a good presentation I did, but I was lost in the Zoom problems with my presentation, so excuses for that. Well, to the people who are interested in machine learning, I would say that machine learning offers a quite a formal possibility to personalize medicine much more, and that might sound to some of you as a contradiction, but I'm fairly sure that that will happen in between now and 10 years, maybe. It takes some time, but it can personalize our diagnostic approach very well, I think, in future.
Thank you so much. Professor van Schaar, could I also ask for your statement, please?
First, I want to say that I was very happy to hear this from Henk about this prediction. So I'm very excited as a patient myself, as a potential patient myself. I'm very keen to develop together with clinical collaborators, and I'm very fortunate to work with some very good clinical collaborators. I'm keen to build such a framework and the underlying machine learning methods, but it's not only the underlying machine learning methods. I think too often people from my community just build tools that are not considering the complexity of the entire diagnostic process. So what this journey together with Camelia, with Alex, with Tim, and with Richard has shown me is how complex the process is. And it is not just risk prediction, it is not just longitudinal trajectories of disease, but what gets involved in building this framework to allow for early diagnosis and estimation of value of test when and for whom is a lot more complex a pathway in its rigorous and systematic thinking together with clinicians to be able to build the right machine learning and the right thinking to empower it. So I'm excited to do so together with them. And I hope that if we can crack it, then hopefully other machine learners could come to our framework and develop even better machine learning methods than we can.
Thank you. Tim Schubert, could I also ask you for your statement?
Thank you, Tim. First of all, I would just like to thank you, Mihaela, Richard, Camelia, and Alex for this incredible journey that we took together. And I think it's amazing that you all devote so much time to this really, really fundamental issue. And I think what we see here is how we can sort of move a medical issue with formalism to a community that's very different from medicine, and sort of really bridge medicine and machine learning approaches. And I really hope that this will help us make medicine and move medicine more from being an art towards a science. And thank you so much for taking this journey together. And thank you for participating today and discussing with us.
And lastly, but certainly not least, Richard, could I have you give your statement?
Yeah, I'm not sure I deserve the honor of the last part, but I'm like Henk. The piece that what really excites me about all of this is the personalization. when you think about the evidence base for pretty much all of medicine today, it derives from population level data, whether that's epidemiology or clinical trials. They're all done in populations, and we use that data to make decisions about individuals in terms not just of diagnosis, but also of treatment. But those individuals are often very different from the ones who were involved in the population. And even if they were similar to the overall population, there's huge heterogeneity within the population. And we've not been able to take account of that in a quantitative and really reliable manner until today. And I think we are now in a position to start doing it. I share Henk's view that this is going to be real. Certainly parts of this, maybe a lot of this is going to be real within the next 10 years. And I think it's very exciting to be a part of it.
Thank you so much, Richard. I want to thank each and every panelist who was here today. I know you have busy schedules, so it means a lot to come discuss this fundamental project. I'm going to let Andreas wrap up in a few seconds, but I also want to highlight that our next session will be about large language models and how it can help clinicians. And I think this is a really big conversation we'll need to have, because it's coming and it's here.
Yeah, thank you so much, Tim, and thank you very much to our speakers. Thank you to Mihaela for this exciting session. Yeah, just as he said, the next session will be about large language models. All the details about this we will send out to our mailing list as usual, and please come and join us. And again, it's our 30th session, so it will be big, and the topic is just suitable for such a big event. Indeed. This recording will be up on YouTube over the next days or so. We will also send this out to you. If you have friends or colleagues who might be interested in this session, please forward this to them, let them sign up and be part of this movement, which is really exciting, just as we heard. So thank you very much and enjoy the rest of your day.